My name is Krishnaswamy and I am a subspecialty registrar in the Department of Urogynecology at NHS Greater Glasgow and Clyde in Scotland. I am presenting a review of autologous fascial slings for primary and secondary stress urinary incontinence. We have no disclosures relevant to this presentation. More numbers of non-mesh continence surgeries are being performed since the mesh pause in the UK. Autologous fascial slings are one of these procedures, and the rectus fascia is currently the only site of harvesting the sling that is currently recommended by the National Institute of Clinical Excellence. A newer variation of performing autologous fascial slings is the sling on a string technique. This was developed to address concerns about surgical morbidity, operative time, and cosmetic results. A strip of fascia from the rectus sheath is harvested and is anchored using either non-absorbable or absorbable sutures depending on operator preference. This is passed through a vaginal incision underneath the urethra to support it like a hammock. It is typically mid-urethral, tension-free or non-obstructive in nature. However, it can be closer to the bladder neck, made to be tight or obstructive in some cases after discussion with the patient and counseling. We looked at success rates in treating stress urinary incontinence when the autologous fascial sling procedures were performed using the sling on a string technique. Women were included in the primary group when this was done as the first major procedure to treat stress urinary incontinence. Those who had prior urethral bulking before opting for autologous fascial slings were still included in the primary group. Women who had a prior major stress urinary incontinence procedure, that is previous autologous fascial slings, colpo suspensions, and or mesh tapes for stress urinary incontinence, and requested for an autologous fascial sling due to failure or recurrence of symptoms were included in the secondary group. The secondary aims of the study were to look at intra and post-operative complication rates, including voiding dysfunction. This was a cross-sectional study, a retrospective review done over 7 years in a single tertiary referral unit operated on by 2 surgeons. Overall, 121 patients were looked at, with 51% being in the primary group. This was the distribution of cases over the years. A majority of cases were done in 2016 and 17. The age ranged between 23 and 78, with the mean in both groups being around 52. The BMI ranged between 19 and 44, with the mean being 30 in the primary group and 32.2 in the secondary group. These were the previous surgeries for urinary incontinence in this cohort. In the secondary group, 75% of women had had one previous SUI surgery. Pre-operative urodynamics were available for 116 women, with the majority having stress urinary incontinence alone. The mean urethral pressure profile was 53.5 in the primary group and 46.6 in the secondary group. Regarding voiding dysfunction preoperatively, 23% in the primary group and 11% in the secondary group had this. In a majority of patients, however, no preoperative voiding dysfunction was seen with no need to self-catheterize. In 18% of the primary group and 5% of the secondary group, there was preoperative voiding dysfunction. However, these women did not need to self-catheterize. 5% in both groups had preoperative voiding dysfunction and did need to catheterize. The majority of women in the primary group, that is 58%, had non-obstructive tension-free slings inserted. The majority in the secondary group had obstructive slings, that is 85%. The most common adjuvant surgery performed in both groups were vaginal prolapse surgeries. Success rates in both groups were high. Overall, this was over 90%. Intraoperative and postoperative complications were low in both groups. Wound infections were lower when women had a BMI of less than 30, that is 3% in both groups. When women had BMIs of over 30, 6% in the primary group, that is 4 women, and 10% in the secondary group, that is 6 women, had postoperative wound infections. Regarding postoperative voiding dysfunction, 1 in 2 women needed to self-catheterize when they were seen less than 3 months after surgery. This fell to being 1 in 4 at 1 year and 1 in 10 over 2 years after surgery. The lowest rates of needing to self-catheterize were seen in the primary group with non-obstructive slings after 2 years of procedure, and this was 7%. To conclude, there was overall high success rates of over 90% seen in both groups with low intra and postoperative complication rates. Overall, 1 in 2 women needed to self-catheterize in the short term, with it being 7% in the long term in the primary group with non-obstructive slings. Thank you for giving me an opportunity to present this, and I'd be happy to take any questions. Thank you.